we just go look at planning error, what are the issues associated with planning error? Because these guides are based on the plan. It's like a computer. What you put in is what you get out. And in this situation, if the plan is not precise, if it's not accurate relative to the actual patient anatomy, then the drill guide will not be usable. Well, I think one of the issues could be is many plans are based solely on osseous anatomy, where while you're planning the case, you can't see the outline of the gingiva, you can't see the opposing tooth, you can't see adjacent teeth. Secondly, there seems to be a perceptual difficulty looking at 3D images in 2 dimensions. This issue was described to me by the owner of a large digital dental lab, who indicated that they faced this problem when designing crowds virtually. And there's a learning curve here in which to overcome this issue, but to be aware of it is very important. And finally, plans based on 3D image with scatter can be a problem. Sometimes critical anatomy is obliterated, or the data merge may not be accurate. So if you have a scan and there's enormous amounts of scatter and you have anatomy that's obliterated, perhaps that's not a case in which to do guided surgery. With Blue Sky Plan and Guided Surgery Solutions enhanced tools, I think that we are able to reduce the planning error. And these are the tools that would be available in order to do that. The plan is based on merged data, showing the osseous anatomy, gingiva, and teeth. Plans can be based on anatomy of the opposing dentition, anatomy of a temporary or permanent prosthesis, a full denture, or an edentulous ridge. We've also introduced the ability to plan on the basis of reference marks, showing pilot hole entry points that are in ideal anatomical positions. Radiographic stents are usually not needed, and we have a scanning protocol for cases with scatter where we still can obtain accurate merges. This slide illustrates some of the enhanced tools that we have available using Blue Sky Plan. It's an extremely powerful software package and enables us to do what we're showing you. In the top left panel, we can see a cross-section of a mandible with an implant in place. But we also can see the outline of the gingiva. We can see an outline of the opposing tooth. And in this case, you can see where we have the implant lined up, a mandibular molar implant lined up with the lingual cusp of an upper molar, is as it should be. In the center panel, there is an image, a 3D image of an articulated dentition. On the top right panel, we have an image of the edentulous area and the adjacent tooth, and you can see a reference mark. And that's a mark in that model which represents the ideal position for the placement of that implant. We also can use the abutments as virtual teeth. For molars, I usually set them at 10 millimeters. They can be whatever you wish them to be. It could be 9 for a smaller molar, 11 for a larger molar. And so you can look 3D on the actual model and see what the relationship would be between your future tooth and the adjacent teeth. And I think these enhanced tools will go a long way to minimizing planning error.